everyone. Welcome to ResearchMD.com. We got a great presentation today. My name is Pramil Cheriyath. I'm a Program Director, Internal Medicine Residency, Transitional Residency in the United States. I'm an Assistant Professor of Medicine, 2 large medical schools. Thank you for joining us today. Today we're going to teach you all about iron deficiency anemia. Okay, that's our topic, iron deficiency anemia. So when you talk about iron deficiency anemia, I think that, anything we kind of talk about is we need to know the prevalence of iron deficiency anemia, right? What is the prevalence? Around like 50%, right? In the world. When you look at some of the African American countries also, it's extremely high, okay? Again, let's start with the definition of iron deficiency anemia: decrease in the total iron content of the body, which body need to make hemoglobin. Okay, that's our definition for today. Remember that. And then we talk about it. And then let's look at some of the causes of iron deficiency anemia. Okay, there is something called increased demand, right? There is increased demand. When do the body needs like more in demand? You got pregnancy, right? Lactation. It could be erythropoietin therapy, rapid growth in the infancy period. Those are the like 4 conditions: pregnancy, lactation, erythropoietin therapy, rapid growth in the infancy. Okay. Now next thing is like the decreased absorption from the system. What condition? When you don't take the diet, that's kind of pretty much, if you don't have enough iron in your diet, that can affect, right? So the first one is like inadequate diet. And then what else do you have? You got like malabsorption, right? And then it could be disease or some surgery, right? You have like a bowel surgery or anything, those kind of things can affect all that. Let's say like when you talk about like Crohn's disease is very common, celiac sprue and all that, decreased absorption, okay? And then you have like surgery, like gastrectomy can also kind of affect those, so we need to be careful about that. So what are the things like increased loss? Okay, increased loss, like what condition you can have, like there's like, female is very common. You got a young female, first thing you always want about the menstrual history. So menses bleeding, I would say. Like, and anytime there's like a chronic blood loss, like hemorrhoids and all kind of things we need to know about. When some people kind of blood donate like more frequently, not like, once in a while is okay, but some people are kind of donating frequently, that's a more increased loss. Even like when you get admitted to hospital, be careful. Like they get like a lot of blood drawn when you get admitted like 6-7 days in the hospital. So everybody got that, right? So let's look at now what are the clinical features. What do they usually people are present with? What do they usually present with? Fatigue, right? What are the other causes? Somebody tell me. Pallor, right? Everybody says that you got pale. And then what else? If you look at patient is going to complain. Can they complain shortness of breath?
Yes.
Mainly like an exertion, when they walk, they get tired or climbing the steps and all that, right? They can be tachycardic, and in the vital signs, they're like heart rate, the body has to compensate, increase the cardiac output, angina. Angina and all that may the later stages, not the initial stages, right? And some severe anemia body need, and then heart need, like heart is kind of telling you, crying like, hey, I need some iron, or like I need some blood. That's the main thing is happening, right? And then PCOP and dysphagia, angular cheilitis, and atrophic glossitis, and koilonychia, like, the spoon-shaped nails, right? Those are the things kind of when you look at it, we need to know some of the findings. Somebody tell me the findings one more time.
This will be fatigue,
pallor,
cardiac, like signs like tachycardia, angina, dyspnea on exertion, pedal edema and cardiomyopathy in later stages. There could be also pica and dysphagia, angular cheilitis, atrophic glossitis.
So angular cheilitis is very common, koilonychia, right? And spoon-shaped nails and all that's very common. Okay. So now we have to look at the pathophysiology. Okay. All about like what happened. The pathophysiology is very important. Now, what are the things we have to look at it right here? When you talk about the iron, right? We have 2 forms. One is like heme iron and the non-heme iron. Usually like non-heme iron is in the vegetarians, okay? The other one, heme, is in the meat eaters and all that too. So when you look at, let's look at first the heme iron, which is in the meat eaters. Everybody knows that, right? What happens over here? They got heme transporter, and then they go through this ferroportin gate, okay? And this is in the ferrous form right here, and then it's converted into ferric form, right? And then plasma transfer and combination are combined and take that to the bone marrow to make all the blood erythroid precursors. Yes, in a nutshell, that's what's happening, okay? Now, they have non-heme iron, the vegetarians now. What happened in the form? They have like the ferric form, right? So you got like duodenal cytochrome B enzyme. They convert this into ferrous form. You need the ferrous form to enter into the cell, okay? And then you have this something called divalent metal ion transporter called DMT1, okay? That kind of help in the transport. They go through the same pathway right here. You got the ferroportin, and then it's converted into ferric form again, and you got plasma transferring, and both combine to take into the heme synthesis. Okay, remember that. So there's also one more mechanism. The heme ion can also go this way, become like a mucosal ferritin storage, and they can usually kind of shed by epithelial cells also. Yeah, when you talk about remember this ferroportin, there's another enzyme, another called hepacestin also has a role in it, okay. Now, the next thing we need to know the role of hepcidin. Okay, hepcidins kind of monitor the iron storage in the body. Let's say you got too much iron there. What do? They just kind of go back and they tell the macrophages to not to break down anymore. And then also this ferroportin gate, they block the gate. Okay, so remember, like this is very important. You need to know. First, you need to know heme iron and non-heme iron, right? And they go through this heme transporter and ferroportin channels, and then become ferric, and then converted, and then go into heme synthesis, right? And then you got the non-heme iron, which is in the ferrous form. Then that need to go to the duodenal cytochrome B, that converted into the ferric form, right? And then dimetallic iron transporter, right? DMT1. And that can take you to the ferroportin gated channels and follow the same pathway. And above all, remember the role of hepcidin, it just kind of monitors it. And then hepcidin, if there's too much iron in the body, just they close the ferroportin, and they also inhibit the macrophages kind of breaking down, right? Okay, so this is in a nutshell. Now, what lab work would you do in a patient? Somebody tell me, how do you check? When a patient come in and say, like, you're suspecting, what are the lab work you have to do? What is the most important lab work, people?
Serum ferritin.
Serum ferritin is very, very important. That's our number. If we have to check, what would be before that, what would be the common finding you will see in the CBC? MCV, right? The first thing is, like, there's going to be anemia, right? We know, like, 12 to 14. It's going to be anemia low, and then we look at the MCV. The MCV is what? Less than 80? Then we can say there's microcytic anemia. You look at the decreased MCV, and what's going to happen to my RDW? Increase, okay? RDW is going to be increased right here. And the most important, my friend, remember, is what? Ferritin. Everybody got that? So ferritin, what is the other role of ferritin? It's also inflammatory marker, also remember. So if somebody's ferritin is like less than 30, your sensitivity and specificity of diagnosing iron deficiency anemia is like close to like 90 to 95%. Okay, remember that. And if it is like less than 15, then again sensitivity and specificity is very high. But what we need to understand, this is not a good tool to use when there is inflammation, okay? Because ferritin is also what? It's an inflammatory marker. Everybody got that? It's an inflammatory marker, ferritin. So if there is a concomitant inflammation is going on, ferritin is like less than 100 is also very significant. Okay, remember that. Ferritin is good, but inflammation, you can say like less than 100 also, you can say there's iron deficiency anemia. Okay? If there's like anemia chronic, there's a lot of inflammation going on. If the ferritin is less than 100, you can say iron deficiency anemia. Everybody got that? So what are the other newer stuff? You can do like there's decreased iron, increased transferrin saturation, increased transferrin, and decreased TIBC, right? Okay. Now, if you do this test, there's new test called soluble transferrin receptor assay. Okay, and the sensitivity and specificity is around 80 to 70% on that. Okay, around 86 to 75. When do we, when you try to differentiate between anemia chronic disease and from anemia due to iron deficiency, you could do that test, but that test is very expensive. Then we can obtain serum free erythrocyte protoporphyrin, and the sensitivity goes up, again close to 90. Okay? Again, what is the gold test? Somebody tell me what's the gold test?
Biopsy.
Bone marrow, you can get a C, like, the bone marrow is the thing. Then the smear, it can be microcytic, hypochromic, and pencil cell. Those are the common finding you will see, right? Everybody knows those, very, very important. Now let's look at the treatment, the most important part of this lecture also. How do you treat it? Okay, what is the first treatment always? Make sure, you can give the diet is very important, right? Educate the people, especially the pregnant people. It's very common to have dietary problems also. So tell me some of the things can increase. As like a higher iron content. Some of the food products. Somebody say louder.
Meat.
Meat. Okay. Red meat, fish, poultry, dark green vegetables, raisins, apricots, and fruits. Okay. Now, what we need to understand, some of the products can inhibit the iron absorption. Some of the things can increase the iron absorption. Okay. When you talk about the increase iron absorption, which I'm going to write it up here, right? Vitamin C. Okay, if you give vitamin C with your food, then there's going to be increased absorption of the iron. Okay, citrate. We'll just put citrate also. Everybody got that?
Yes.
Okay. All right. Now, which one inhibit the iron absorption? Okay, can you tell somebody? Which drug? If somebody is on one drug, we need to be PPI.
Yeah.
Okay. What is PPI? Protonum inhibitor. Okay. Oxalate, phytate, polyphenols. Can I write it down? Oxalate, phytate, polyphenols. Okay. These compounds can inhibit. So it contains, it's in tea, right? Coffee. Remember that. If somebody is drinking a lot of coffee and all that, if you look at it, iron is absorbed very less. Even if you take a large amount of iron and only very tiny little bit get absorbed in the body, that's a problem. So that's why the treatment lasts you have to treat for like 6 to 12 months to get enough iron in the body and all that. So everybody got that? Remember, okay? And the oral iron, it could be ferrous sulfate, fumarate, and gluconate form. You usually give 325 milligram TID. But what we're looking for is this is our goal. You have to get the 65 milligram elemental iron. Okay? That's the goal. Everybody got that? Somebody tell me what's the dose again one more time so to make sure everybody knows it.
It's 325 mg. So
what? 3 times a day.
3 times a day.
Okay, what are you looking for?
65 mg elementary.
Elemental iron. That's the content in there. Okay? So target is like you have to treat the anemia and then you have to replenish the iron stores, which is 0.5 to 1 gram of iron. Okay, everybody got that? And treat for how long? Somebody said that?
6 to 12
6 to 12 months. Okay, and after correction. Okay, lack of response, usually people non-compliant. People take iron, stool color, constipation. That's like everybody said that. That's like very non-compliant people right here. Continue blood loss because you're not treating the actual problem. Somebody's having GI bleeding and you're not treating the hemorrhoids and those kind of things could happen, right? Menstrual bleeding is also very common. Now, another important treatment is like IV iron therapy. Okay, which conditions we will use IV iron therapy? Which one is indicated? One is like congestive heart failure. Okay, instead of giving oral iron, it's better to do what? IV iron. Okay, and then chronic kidney disease also number one priority should be IV iron, not oral iron. Remember that. What is the other one? Inflammatory bowel disease, you can do oral or IV iron. And malignancy IV iron is recommended elderly, and the pregnancy hemoglobin less than 11, and the ferritin is like less than 100 grams. You can use IV iron. Okay, one of the complications of IV iron, Okay, what is the most common? Somebody tell me, like, what's the most common complications of IV iron?
Hypersensitivity.
Hypersensitivity is very common. Okay, allergic reaction. There are the reports of patient death and also, so to be prepared to treat that. What is the other electrolyte abnormality IV iron can cause? Somebody tell me.
Hypophosphatemia.
Hypophosphatemia, very important. Okay, so hypophosphatemia, what does it kind of cause? It can cause like osteomalacia and all of that. So what happens is like in this IV iron, you got the ferric carboxy maltase and carbohydrate moiety. Okay, they inhibit the degradation of fibrin growth factor with 23. Okay, so what happens is like that increase the phosphate wasting in the urine. So all the phosphate is kind of go through, you pee out. So you're going to be decreased phosphate, and that can cause like bone loss, osteomalacia, and those kind of things. Remember that. Okay, two things again. Somebody told me again, very important. IV iron. Two things. One is hypersensitivity, right? The other one is hypophosphatemia. Okay, so the way you calculate the IV iron dosage, you take the weight, kilogram 2.3 times, and then 50 minus weight hemoglobin plus 500 or 1000 milligram you can use. Okay, that's for the storage. Now, preparations, it can be high molecular weight iron dextran, ferrium oxytol, iron sucrose, low molecular weight iron dextran, and all of that can use it. Okay, and then we talk about adverse effect. We already talked about the hypersensitivity, hypophosphatemia, the role of ferric carboxy maltase and carbohydrate moiety. They inhibit the degradation of the fibrin growth factor, right, 23. So phosphate is kind of like, wasting through the urine. Very important 2 points, okay? And then RBC transfusion, I think everybody knows that. Like, the hemoglobin, we used to transfuse for everything before, unless the hemoglobin is less than 7, we should not transfuse. Studies have shown by giving transfusion, people are dying. That's why we don't transfuse. But again, you have to look at every situation, right? If somebody have like CHF or like cardiac conditions or having angina pain and you have coronary artery disease, I would say like maybe 8 is probably like another cutoff. Remember that. Okay, so 7 and all that too. So just in case, just going to summarize everything for us one more time right here. Number 1, what is that? 50% of the global, prevalence. Africa, my goodness, 71%, right? And then you have all this increased demand in pregnancy, decreased absorption, inadequate diet, increased loss, menses loss, chronic blood loss, and all of that. And the common complaint, especially say like I'm fatigued, that's the most common. You can have like tachycardia, you can have like shortness of breath, and then you have all this, the skin finding, like what is ankylosing, atrophic glossitis, and koilonychia, and all of that, right? And now we come up with a famous diagram. It's very important to know the pathophysiology. You got heme iron and non-heme iron, right? The non-heme iron is in the ferrous form, right? And then just go to the heme transporter, and you got ferroportin with gate, and then it's kind of converted to the ferric form, and the transferrin saturation, you got the heme synthesis. Everybody got that, right? And this is the normal mechanism. And non-heme iron, this is the vegetarian's problem. This is more, they get the plant, the non-heme iron. And again, they have, it's very hard for them, the body to absorb in that capacity. So it's already in this what form? The ferric form, okay? But in order to enter the cell, what do they have to convert it into? Ferrous form. So what is the duodenal cytochrome B that converted into? Ferrous form. And enter the cell and divalent metal transporter. Remember that role. And then come to ferroportin, and they follow the same pathway, right? And then you have another pathway right here, mucosal ferritin, and kind of get goes shedding the epithelial cells. And then always remember the role of hepcidin. Somebody tell me, what does the hepcidin do?
So it inhibits absorption of iron.
Yeah.
So ferroportin when there is.
Okay, so you just work on, does it work on the channel?
Yes.
Does it close the channel?
Yes.
Yes. Okay, everybody know that.
Right.
Okay, and then what happened to the macrophage? What does it do to the macrophage?
It inhibits the secretion of iron from the macrophage.
Okay, alright, got it, just as long as you remember. And then, the role of ferritin. right? If it is less than 30 and less than 50 in sensitivity and specificity, very high, but at the same time, ferritin also inflammatory marker. If there is like chronic inflammation, if it is less than 100, I would say iron deficiency, right? And then you can also check the soluble transferrin receptor assay, which is very expensive. That's why we don't do. Okay, but the sensitivity and specificity high, you may be able to you will be able to differentiate between anemia, chronic disease, and iron deficiency. And then you have another test, obtain serum-free erythrocyte protoporphyrin. Okay, and the sensitivity and the specificity around for that one is extremely high, up to like 90% sensitivity and specificity. Remember that. And then we have this. The main thing we need to understand is this food product, and main thing we need to know tea and coffee inhibit, okay? And the proton pump inhibitor, when you have a lot of patients on proton pump inhibitor can inhibit the absorption, because like we already said, iron is like very, very hard to get absorbed in the body. So when you have this tea and coffee drinking and somebody's on proton pump inhibitor, you're doing like more damage, remember that. And then if you give vitamin C and what is the other, citrate, the absorption is more. That will help the patient. Just give some vitamin C and citrate with it, okay? And then we know how to treat it, and we know, like, which situations we can. Somebody tell me which situation really fast we use IV iron.
Congestive heart failure.
Congestive heart failure, yes.
Chronic kidney disease.
Chronic kidney disease.
IBD.
Malignancy, elderly, and the pregnancy. We got some numbers. Hemoglobin less than 11 and the ferritin less than 100. And we always talk about the complication of IV iron, which is hypersensitive reaction and the hypophosphatemia, renal wasting. Okay, so we talk about like what happens in there, and then you have to make sure like you treat hypersensitivity, and then watch out for hypophosphatemia, which can lead to osteomalacia, bone problem, and then again the last thing is the one you want transfusion. Only hemoglobin is what? What is the magic number?
Less than 7.
Less than 7. Thank you so much, my friends, for watching today. We'll be back with another presentation. Please subscribe to our channel. It will be very helpful, because all these videos take a lot of effort from a lot of people to make videos like that. Thank you.